Good morning, everyone. Good evening for people joining in from US. We are on the 61st session of International Speaker Forum Association with SIMAO. And so we will introduce the guest and we will introduce the speaker. And then as we move forward, we will open the forum for other medical association. So today, we have Dr. Rohit Agarwal. He's a rheumatologist and a professor of medicine in rheumatology department of University of Pittsburgh, USA. He's also the medical director of Arthritis and Autoimmunity Center at University of Pittsburgh Medical Center. And he will be presenting a topic which I will let him introduce. And over to Dr. Rohit Agarwal. Dr. Rohit, you're on mute. Oh, sorry. Okay. Sorry.
Yeah, thanks, Saurav and Dr. Chong and the organization for inviting me to present this talk. I'll be talking about JAK inhibitors in their role in COVID. So if you can allow me to share the screen, I have a few slides to present. Okay, that's good. Can you see my screen now?
Yes.
Okay, so the topic is JAK inhibitors in moderate to severe COVID. You know, as I'm a rheumatologist, we use JAK inhibitors. We've been using JAK inhibitors for years. And so I thought it'll be a good topic for me to touch about at least my experience about, the efficacy and safety of JAK inhibitors in general. I don't have that much experience with treating COVID patients in US. But little bit. But actually, I have more experience now after COVID Indian crisis of giving JAK inhibitors to patients in India because of this last month's severe crisis. So, first of all, you all know, this audience know very well what cytokine storm is. So I'm not going to go over too much detail. But basically, what happens is, for whatever reason, COVID leads to cytokine storm, leading to severe ARDS type picture in COVID patients, which is a leading cause of death in COVID-19. Also, it can lead to other organ involvement, including kidney, brain, vasculature, primarily because of endothelial cell disruption and angiogenesis. Plasma level of pro-inflammatory cytokines like IL-6, as you very well know, is very highly elevated and is actually an indicator of prognosis or mortality in patients with COVID. And actually, this pathway and other cytokine pathway can be blocked by JAK inhibitors. So, first of all, what are JAK inhibitors? JAK inhibitors is a class of drug. These are oral molecules, and there are multiple different JAK inhibitors available now. But all of them basically block different type of JAK 1, 2, 3, or TIC 1, 2, 3, and what they do is, by blocking the JAK, they block these these cytokines, IL-2, IL-6, IL-12-13, interferon, EPO, and other cytokines. So these JAK inhibitors, different types of JAK inhibitors, block different types of cytokines, but they're not one particular. They're not inhibiting only one particular cytokine, which is the advantage of JAK inhibitors in using for autoimmune and inflammatory diseases, that it actually blocks multiple different cytokines. Baricitinib per se is a JAK inhibitor that we will discuss. This is a proposed dual mode of action. One, it can actually add by reducing viral infectivity through inhibition of something called NUM-associated kinase, thus leading to decrease in viral endocytosis. But more importantly, what we want to use baricitinib is sort of for its anti-inflammatory mechanism through the blockage of JAK1 and 2. So I'm going to present 3 studies today for the data of JAK inhibitors, specifically baricitinib in patients with COVID. So this is a really nice study. There are 2 cohorts here, one from Pisa and Italy, and one from Albicete University in Italy. And what they did is they treated these patients with baricitinib in most cases, but they also had a control arm where they had a PS matching, which is called propensity score matching, of the patients who did not receive baricitinib. So they had a baricitinib arm and a non-baricitinib arm, but it was not a randomized controlled trial. I wanted to clarify. This was a general, observational study where they had some patients on it, some patients not on it, but then they compared by doing matching, one-to-one matching of these patients. These patients were also, in addition to baricitinib, who got baricitinib, were also another concomitant antiviral therapy. At that time, hydroxychloroquine was, was in trend. So they got hydroxychloroquine, they got different antibiotics, corticosteroid, low molecular weight heparin, as well as lopinavir and ritonavir. Overall, the groups were very matched. 83 patients in baricitinib group got the drug, and 83 patients were matched, propensity score matched. And what they found was death or invasive ventilation was basically 16.9%, about 17% in baricitinib group, as compared to almost double in the comparator group, with highly statistically significant results. And also, there is a multivariate Cox regression model. As you may know, only one factor may not influence the outcome. So they actually did a multivariate regression in which giving baricitinib had a very high probability of preventing death or mechanical ventilation in this model. This graph to me was the most striking graph. This was a Kaplan-Meier curve. And in the patients who did not receive baricitinib, is in red, and patient who received baricitinib is in green or blue, where you can see the effect of drug is quite early. Within 5 to 10 days, you start to see this mortality benefit, which was shown in this study. Again, not a randomized controlled trial, so you have to take it with a pinch of salt, but at least the mortality-wise, they were able to show a significant difference early on. With that, also the safety, a lot of people have concern about safety of baricitinib. In this study, at least, there were some liver enzyme elevations, but they were not a lot. And most of them did not require stopping the drug. Only 4 patients had to stop the drug out of 83 because of liver enzyme elevations. And there were 1 or 2 cases, I think 1 case of lymphopenia, which is difficult to say, was it baricitinib or was it COVID and other reasons. There were 14% with other infectious complications, in the cohort, in the PISA cohort and the Spanish cohort. There were no coagulopathy or thrombosis. However, most of these COVID patients were given low molecular weight heparin. Now, this leads to the second study, which is the major study, was published in NEJM. This was a major randomized controlled trial on baricitinib plus remdesivir for hospitalized patients with COVID. So in this study, this was a randomized controlled trial of more than 1,000 patients. So this is a very well done study, 1:1 randomization of baricitinib plus remdesivir versus placebo and remdesivir. So what they showed is what the overall primary outcome was time to recovery, which was statistically significant, 7 versus 8. So you would think, 7 days of recovery versus 8 days of recovery is really not that big a deal, which is true because they were looking at all comers and overall time to recovery. But if you select a population of patients where these patients requiring oxygen or non-invasive ventilation, you see a dramatic, almost double the effect, where 10 days for recovery for baricitinib group as compared to 18 days in this study, which was highly statistically significant. In terms of adverse event, grade 3 or 4 adverse event was similar, in fact, slightly more in placebo with remdesivir as compared to baricitinib with remdesivir. And venous thromboembolism was almost the same in both groups. So the conclusion drawn from the study was baricitinib plus remdesivir was superior to remdesivir alone in reducing recovery time and accelerating improvement in clinical status among patients with COVID-19. And this is most notably amongst patients who are receiving high flow oxygen or non-invasive ventilation. Last but not the least, I'm going to go over Lilly's study. This was a phase 3 cove barrier study of baricitinib in hospitalized COVID-19 patient. As you may know, in US, you need 2 phase 3 study to prove anything. So this was a second sort of phase 3 study of baricitinib plus standard of care versus placebo with standard of care. Now here the standard of care was corticosteroid, anti-malarial, antiviral, or azithromycin. They studied more than 1,500 hospitalized patients. Now, this study primary endpoint was proportion of patients who progress by day 28. And the progression was defined by first occurrence of non-invasive ventilation, invasive ventilation, or death. And it did not meet the primary endpoint. However, if you look at the death or mortality difference, it showed a significant reduction of mortality in baricitinib group by 38%. So 8.1% patient died in baricitinib group as compared to 13% with a significant hazard ratio. Now, the other point I want to make is, again, if you look at the patients who were on non-invasive ventilation and then see which patients survived or not. Now, we're basically selecting more sicker patients. So then you see there's almost, again, you see the doubling effect where 17.5% patients on baricitinib died as compared to almost double, 29.4% patient on placebo group died. Again, we see the same trend. The serious infections and venous thromboembolism was almost similar in both the groups. So wasn't any major signal of increased adverse event, at least in terms of infection or thrombosis. Now, because of that study, it led to an FDA approval, which was not a full approval, but emergency use approval to use baricitinib in combination with remdesivir in patients with COVID who are hospitalized, specifically if patients are requiring supplemental oxygen, invasive or non-invasive ventilation, or ECMO, which means basically a hospitalized patient who has significant disease. And that all of this data then eventually was presented to Indian FDA, which really led to this approval of no, actually, this is wrong announcement. Sorry, my mistake. But this led to approval of baricitinib in India by Indian FDA, I think in May sometime. Baricitinib, how is it given? It's a pill, so it's very easy to give. It's 4 milligrams a day. You typically give it for 7 to 14 days or until discharge, whichever is earlier. Hospitalized patients, I would recommend it only in hospitalized patients who are requiring oxygen and who clearly have COVID with high CRP. With that, thank you. And I'll take any questions now.
Thank you, Dr. Rohit, for a nice presentation on an important topic. I would like to invite our chair, Dr. Chong from Singapore. And before he can come forward, I would like to acknowledge the presence of Dr. Meenakshi from India, Dr. Jamaluddin Chaudhary from Bangladesh, Dr. Angelica from South Africa, Dr. Brahm Vasudev from US, Dr. Sanchita from Heartcare India, Dr. Ravi, past president in Simao and Malaysia, Dr. Marie from Japan, Dr. Pillai from Sri Lanka, and also the member of World Medical Council, Dr. Monica Vasudev from US, Dr. Ashraf from Pakistan, Dr. Russell from UNESCO and Australia, Dr. Chong again, Dr. Chong from Singapore. So you've been acknowledged twice.
Thank you,
and we will see more people joining in. I saw some people, I think they left maybe because of the connection. So over to you, Dr. Chong.
Thank you, Sarab. Can you hear me?
Yes.
Yeah. Okay, great. Thank you, everyone, and particular Dr. Rohit for such a great presentation. Honestly, over here, I'm not so much involved in, as you rightly said, in treating severe COVID patients. But certainly the data looks very, very impressive. Just a quick question before I throw the questions open to the floor. So most of the effect is due to shutting down of the cytokines. Or is there particular cytokine that is actually, more equal than others, if you know what I mean?
Yeah, I think IL-6 and interferon, those are the two cytokines where baricitinib or JAK inhibitor really believes to work. And a lot of people believe that COVID infection leads to these two cytokines to be significantly elevated. We know IL-6, but to me, interferon is as important as IL-6 in COVID.
I'm just curious, when we give these vaccines here in Singapore, we once in a while we see some of these side effects. And I remember that our late president always used to say that we're giving the patients muscle COVID instead of lung COVID. Is there activation, you think, of the interferons and the IL-6 as well when we give these mRNA vaccines?
That's a good question, to be honest. I think Dr. Monica might be better able to address the vaccine question. Does the vaccine lead to IL-6 or a response or not? I mean, Dr. Monica, would you comment on that?
So when you see the side effects with vaccination compared to severe COVID disease, you're seeing a much broader and you're seeing a much higher rebound or acceleration of the immune system with infection. So if in terms of specific IL-6, even if it is produced, it'll be in such minimal amounts compared to what you're seeing with patients with advanced COVID disease, compared to those who have asymptomatic infection versus those who have no symptoms with vaccination. So I'm sure that the immune profiling with the vaccinations is very different than native disease because we are only targeting the immune system to the spike protein, which is manufacturing mRNA versus the native infection that has a much broader and stronger cytokine storm.
Yeah, I'm asking this because my last patient before I started the Zoom was very interesting. He had his COVID vaccine, Pfizer, about 3-4 weeks ago, and subsequently developed uveitis, and he never had it before. And he was also HLA-B27. And the last follow-up a few days ago, he finally we managed to look through the lens, of course, uveitis, everything was all fogged up. And we found optic neuritis. So fascinating. I just finished seeing him before I came on the Zoom. Yeah.
It is well known that, vaccine in general, but also this particular vaccine can lead to aberrant immune responses leading to autoimmunity. So, and specifically in patients who are more predisposed. I mean, I recently had a patient who developed, almost, lupus-like syndrome after getting vaccine. The point I think I may still make is that, yes, these will be really case reports. That means you're talking about rare cases as compared to millions, almost all the population, half of the population in US have received vaccine. And whereas we are, excited when we see such a case now. So that means you can appreciate how rare is this.
Yeah, exactly. I mean, so we reported it to our authorities here of him, this patient with optic neuritis and uveitis. So yeah, tried to persuade him to take high dose steroids, but he refused. So so I'm sure he's aware he might lose his eyesight, but it is what it is. So thank you very much. That was my question, and now I'd like to throw the session open to the floor and welcome any questions from the floor for our speaker.
Thank you, Dr. Chong. Thank you very much, Dr. Rohit Agarwal, for your nice presentation. I am Dr. Jamaluddin Chaudhary from Bangladesh. Would you please tell us this advantage of the baricitinib over tocilizumab or something like that?
Yeah, so tocilizumab is a specific interferon inhibitor. Basically, it inhibits IL-6. So the major advantage to me would be that baricitinib is a general cytokine inhibitor. So it basically inhibits multiple cytokines. So in a lot of cases, I feel if you're not sure that it's an IL-6 driven problem, then using baricitinib might be better or easier. Plus, it's a pill, that might be an advantage, but it's difficult to say that baricitinib is better than tocilizumab. You cannot say that. It depends on the situation. There's no head-to-head study to say. It's basically having another drug in your armamentarium to say, okay, we could use this or this. So, I mean, I know a lot of doctors have received really, positive outcome in tocilizumab per se. So it's tough to say which one to use as a cytokine inhibitor. The little advantage I would say is baricitinib has is it does inhibit multiple cytokine, including IL-6 and interferon. But having said that, if IL-6 was the main reason, then tocilizumab probably would be a great drug as well.
But tocilizumab is costlier than baricitinib? Tocilizumab is costlier than the baricitinib?
That's a question that I think the Indian doctors probably can answer better, because I'm not here in US. There is no way to figure out cost. It's so opaque system to know the cost. Even the doctors don't know the cost. So,
but here in Bangladesh also we have to think about the cost also.
Yeah, no, I agree. Cost is important.
We are giving more broader spectrum than for. I feel.
So yes, so I think tocilizumab is a little more expensive as compared to baricitinib. Of course, tocilizumab is only to be given in the hospital settings. Dr. Rohit, are you recommending the use of baricitinib in COVID patients and outpatients as well?
In most cases, no. I would not recommend that. I mean, I have given it a couple of outpatient, but that was mainly because those outpatients could not get a hospital bed. So, I mean, technically they would be hospitalized patient because they were requiring oxygen, they were requiring steroid, and they were deteriorating with their cytokine profile, like a CRP is going high, IL-6 going high. So in those situations, I have given, I have recommended baricitinib in those patients with good outcomes. But typically I like to see clear-cut cytokine storm post-viral infection. So in other words, so the viral replication phase is over. So generally at day 7, or 6 or 7 or around that time frame where you clearly see that the patient is progressively getting worse.
And of course, the immunosuppression with baricitinib is much lesser as compared to tocilizumab.
Yeah, the other thing with baricitinib or any of these drugs is, you remember, you're only giving it for 7 to 14 days. So it's not going to lead to a severe long-term immune suppression. I mean, this is very short-term, and it's not going to be as bad as steroid. So you're giving much higher doses of steroid. Steroid is your bigger problem in terms of infection. These drugs can cause severe infection, but steroid has much more likelihood to cause infection than any of these drugs, especially when they are given in short-term basis.
If I may, so there are a lot of Indian doctors who are preferring tofacitinib. Do you have any experience with that?
Yeah, so tofacitinib is another JAK inhibitor. It's essentially, I don't have any experience with that. Just because baricitinib got approved, that doesn't mean tofacitinib doesn't work, because it's essentially a JAK inhibitor. It does inhibit JAK1, 2, and 3. So presumably it should work if baricitinib work, but there is no direct data or proof of it.
Right.
Any more questions from the floor?
Just one question. Maybe Dr. Monica can help me here. These complications of vaccination, like for example, now the uveitis and all that, is it going to be reversible or is it going to be a permanent damage?
So that's a great question, and I don't think we know yet. I think that, especially in these the age of these mRNA viruses or vaccines, where they're looking at the mutations in these viruses and they're making changes right now, and they're doing studies on these mutations on the spike proteins and how it's being corresponded in vaccines. I am not sure. I mean, there's new reports now coming out with these Pfizer vaccine in boys who are 16, 15 and older who are having myocarditis. So I feel like, every week we are finding out something new about these vaccines that even on the short-term basis, we're still learning. And long-term, we do not have any idea. But I think the discussion is about what is the risk benefit of the vaccine, not against not getting the vaccine, but against getting the infection. And so, when your number of cases have decreased, it's very hard to convince somebody who has been indeterminate whether or not to get the vaccine if they've been hearing negative reports in the media, versus everybody who's now facing this, tragic surge in India, where if they had access to any of these vaccines, then you would have had so many more people getting it, even at the expense of potential long-term sequelae. What we're going to see now as a tragedy from what's happened in India is that those who are surviving the infection, we don't even know what the sequelae in this particular variant is going to be. So I think the comparison is in terms of benefit of vaccine is what's the sequelae of the infection versus the vaccine. And I don't think that we know, and I don't think we're going to know for a while.
Thank you.
Dr. Monica, do you have any further comment on the Israeli trial, which has shown the myocarditis because of this Pfizer vaccine?
No, not yet. I know that the US, at least on our side, we're collecting data still, because the report came out. So we get daily reports from our state medical societies, and we get our national updates. So we just got this report in the last 48 hours saying that if you have a child who's 15 and older, who is a male, and they have these symptoms that are consistent with myocarditis, the clinical phenotype is mild, you give them NSAIDs and they will recover from it, but you should recognize it for what it is. So that's a very local study. What would be nicer to see is when we start having mass immunizations of much larger numbers of this younger age group, that what is the numbers that we're seeing? And again, what we see in one area doesn't necessarily equate to what we see everywhere else.
Thank you.
Very
Dr.
interesting,
Chok,
Dr.
can I have-
Vasudev. Yes.
Dr. Chok, can I have a question from for
Yes, please, Dr. Chaudhary,
Dr.
please.
Angelique, Dr. Angelique? Dr. Angelique, you're here?
Yeah, I'm listening.
Oh, thank you so much. Dr. Angelique, you had a problem with the vaccination initially. You just this stopped or paused the J&J vaccine, which I remember. But later you started again. But what about those people actually getting their first, not J&J, probably some other vaccine, first dose?
AstraZeneca.
What about the second? What about
AstraZeneca.
Yeah. This is AstraZeneca. This is a Oxford
Yeah.
vaccine. So what about the second dose? Was it mixed one or just postponed?
Okay, so we didn't use the AstraZeneca because AstraZeneca has shown not to be effective against our, or very effective against our South African variant. So right from the start, we didn't use it. And I think that might be a problem in some of the other countries also having the South African variant. Therefore, we opted for Johnson & Johnson and Pfizer with better studies at that time. We still hasn't approved any of the other vaccines that the other countries are using. Again, because some of the data has not been given to us on our own variant. And for us, it is very important to make sure that whatever vaccine we are using are much more effective against our second or our variant that is causing most of our infections. So that is where we are. We have only just recently, the last 3 weeks, started with the Pfizer vaccine. So it's too early to say what we are going to experience regarding side effects. The other thing is we have, because we are struggling to get in enough Pfizer vaccines, we have expanded the second dose from 21 to 42 days. So next month, would be the patients coming in for their second dosage only. Thanks.
Thank you.
Thank you, Angelique.
Can I ask one question?
Yes,
Mr. Chong?
please. Yes,
Yeah.
Prof. Yes.
Thank you very much. Thank you, Rohit. I'm Dr. Ashraf Nizami. I'm from Pakistan. Thank you very much for excellent presentation. Very impressive and a great source of learning indeed. I would like to ask that in US, is there any age limit for what age, as the Singapore now they have started here in our part of Asia from the 15 years for the vaccination. In United States or the internationally, what are the recommended age limit to start the vaccination?
I think it's right now it's being given to adults only, so 18 or above, and then there's only selected population that you could get through for kids through studies, right, Monica? Or is it open to?
It's open now. Pfizer has been open now for several weeks now for 12 and older.
For 12
Even
and older.
the 12.
Yeah, so anybody can get the Pfizer vaccine now, and actually there's an abundance of anybody can get it. It's not triaged based on any risk factors. Yeah.
Monica, one thing that you speak about, what I have the understanding over here in Pakistan and what we are promoting, whatsoever the kind of vaccine is available, nothing differentiating, I mean, about the Pfizer or the Chinese vaccine. I mean, there are multiple, CanSino is there, and some other vaccines from China. And do you feel any difference, I mean, particularly speaking about our part of the country like India, Pakistan, Bangladesh, and so on, that whatsoever, but I'm representing Pakistan Medical Association, but we are promoting over here that regardless of all these firms, whatsoever is available, we have to go for the vaccination. Any comment, please, Monica?
Thank you so much for that question. And that's a fantastic question because this is about vaccine distribution, access to healthcare, equitable distribution. And so what you said is fantastic. That's exactly what we do here. No matter what is available, any vaccine should be available. If you think about it from a large population perspective, if you have a variety of vaccines and the vaccines all have a different efficacy in that moment of time, right? These vaccines were tested when a certain variant was present. We now have different mutations that are present. So the efficacy of the vaccines that we have right now are actually different than it was that's been published at the time that they had launched these vaccines. If you introduce a variety of vaccines, one will definitely work better than another based on what the viral mutation is at that moment. So it's a moving target. And I agree with you that there is no, that whatever is available, you should get. We should not have vaccines that any doses that are wasted. Whenever you have a vial that's been left thawed, that we should be able to utilize every single dose from it, which means that everybody who's standing in line should be able to get it. The only recommendation that I have regarding these vaccines is that in our world, the Moderna and the Pfizer have the polyethylene glycol excipient, and the Johnson & Johnson has the polysorbate excipient. So if there's any concerns related to a potential allergic reaction to any of the excipients in the vaccines, then we might say, let's make a recommendation. Or if they cannot drive a distance or the vaccine is not available for a second vaccine, then I will say let's make a recommendation to get the Johnson & Johnson because it's a single vaccine dose. So those are the kind of the minor things that I would recommend, but otherwise I agree with you that we should not be making any specific recommendation because whatever we know about it is old information in terms of efficacy. That information we got based on variants that were present in the population that it was being tested, and that dynamic is different today.
Thank you.
Thank you, Monica.
Dr. Monica, do you have any? We are practicing the mixed type of vaccines, mixed for a person.
You're talking about mixing and matching vaccines?
Yes, mixing.
So not right now. So that's being done on a research basis, or it might be done in countries where there's no access to the second dose of the first vaccine that was administered. But in terms of what we are doing here, patients or people who are getting the first dose vaccine at a certain location are returning to that same location for the same type of vaccine. I know that if, like, for example, the AstraZeneca vaccine was, the vaccine was not distributed or the distribution was halted. And so therefore there were some countries that had gotten the first dose and couldn't get the second dose. In those scenarios, I think that it is important to get the vaccine no matter where you can.
Thank you, Monica.
You're welcome.
If
John,
there are no
can I
more
ask
questions- Yes.
one question to
Yes,
Monica,
Prof.
please?
Yes,
Yeah,
please,
thank you.
Prof.
Thank you, Mr. John. Monica, can you share your experience as here we have some vaccines like single dose vaccine and double dose vaccine. Is there any, comment on this issue or the
Yes.
concern?
Yeah, so, okay, so we only have access to Johnson & Johnson, Moderna, and Pfizer. So in my world, I'm an allergist and I'm an immunologist. So I get patients who come to me, especially the healthcare providers, who get the first dose vaccine and then the allergic reaction. Is whether or not they should receive the second dose, and I'm risk stratifying for them. How bad was the reaction, and how much immunity have you already gotten from the first dose? So we have a special lab where we can look at the IgG levels to the spike protein antigen, as opposed to the general IgG based on have you had the infection. And in every single patient that I've evaluated, which has been 6 so far, they've had very high levels of IgG to the spike proteins to the first dose. Now, from an immunological perspective, if you get a first dose exposure, whether it's to the virus, whether it's to a vaccine, whatever the allergen source is or the immunogen is, the second dose always provides even a much better response, unless there's some other factors. You're on steroids, you're immunosuppressed for whatever reason. So as an immunologist, I always prefer 2-dose vaccines. I think you'll develop more antibody. However, having said that, I don't even know if we know right now what the right answer is, right? But just based on our understanding of how these work. But again, for patients who are needle phobic, who cannot drive to get there's a lack of being able to get to the vaccine, that single dose vaccine is the best thing for them.
Also, I wanted to, Monica, I wanted to say that I have, I think, evaluated now, 15 patients post-vaccine without antibody to spike protein. And one of them was negative. And that created the whole hell loose situation where the patient was partying and was thinking that he or she is immune. And it turns out she was not. And this has actually been reported in CNN as well to multiple patients who have had this experience, very few of them. So this is causing a lot of uproar, at least in US. Part of the two problems here. One is we're not 100% sure what these negative tests against the spike protein, immunoglobulin, IgG would mean. But so the question is, are they still protected or not? Should they get a third booster to vaccinate, and what's the reason why they did not get vaccine, why they did not get a response? And one of the reasons, at least in my experience, is immune suppression. We know that immune suppressive drug clearly decreases the vaccine response, but we also know in most cases, as I told you, 15 patients of mine all were on immune suppression. In most cases, they will be able to mount enough immune response against the vaccine, from the vaccine, that will be enough to prevent a serious infection from COVID. But in some cases, you will see some patients will be negative. What should we do in that situation is clearly unknown. Monica, any comments on that?
Yes. So whenever I see a lab test with a negative antibody test, I always repeat. Because you're looking at two things, right? You're looking at level of antibody, but you're also looking at the time from the infection or from the immunization. So we're assuming that everybody is making antibodies right away. So first of all, if it's been 4 to 6 weeks after you're getting the injection to when you're getting the antibody, I will repeat the test. The second thing is if they've had 2 doses of the vaccine and they've not had any antibodies, The other thing is that you will be anticipating that there is going to be an endemic form of SARS-CoV-2. We're going to get boosters in the fall. There's going to be anticipated boosters in the fall. So my suggestion to them is be a little bit more patient, continue to use common sense in terms of how you interact with the world, anticipate the booster in the fall, and then check the antibodies again 4 to 6 weeks after that booster shot to see if there's some antibody responses. A corollary to that is if I have a patient that comes to me who's been stung by a bee, if I check their antibodies to see if they have antibodies to the bee venom 2 weeks after they've been stung, they're negative. The antibodies will be negative. If I wait 4 to 6 weeks later, I'll find the antibodies if they have an allergy. So timing is very important from the time that they receive the immunization.
May I ask Monica?
Yes, Prof.
Yeah, thank you. Monica, I would like to ask other way around. If a person have antibodies, IgG, if you say 5-fold or 6-folds, can a person go for the vaccination, for additional vaccination? I mean, there were the trials over here in Pakistan when we went through, and there are certain people who have the IgGs, antibodies, positive, reactive. Can a person go for the vaccination, for the routine vaccination? Please, Monica.
Definitely. Okay, so when you have a native infection, so I'm assuming that the question is of a person who's had the infection and is found to have antibodies. When you have the infection and you develop antibodies, you're developing antibodies to all the different components of the virus. When you get the vaccination, you're developing antibodies to the spike protein. So if you've had native infection and you've had the vaccination, you actually get the best of both worlds. You have serology or antibodies to the native virus, and you have serology or antibodies to the spike protein. So native infection and vaccination immunity, totally different things. And therefore, having the benefit of both, provided that you didn't get really sick, is actually a very positive thing. And yes, I am recommending all my patients who have access to vaccinations and who have no contraindication, even if they've had the infection and have had antibodies, I'm still encouraging them to get the vaccination. And in the US, we're not testing antibodies routinely for people unless we're in a very specific situation. Patients can't just go up and say, hey, I want an antibody. We have to have a reason for it. The insurance has to cover it. They have to go to a specific lab. They sign a consent form. So in most cases, if patients had the infection and they have antibodies, we don't even know, and they're all getting vaccinated. But I do encourage it because the type of the immunity is heterogeneous and variable to native infection, and the immunity to vaccination is homogeneous, native to the spike protein, and very high. So therefore, it is beneficial to receive the vaccination.
Question was about a person who had already infected by COVID-19, had IgGs good in developed, then had the vaccine, which was under the trial what we had in Pakistan. And luckily, he had all IgG in good times. And can that person go after 6 or 9 months for the second vaccination process? This was what I was asking about. Thank you.
Yes, they can definitely get the booster in the next season. Because also, I think that they're going to all change the vaccines in the fall. All the trials are happening right now. So even if they got, say, Moderna or Pfizer or AstraZeneca,
whatsoever,
I think the vaccine that we're going to get 9 months later is going to be different than what we had earlier.
Thank you.
Actually, I didn't get it, actually, Monica. That's actually the infected person getting first dose, when he should get the second dose as a schedule, like that, in case of Pfizer, Moderna, 4 weeks, and in case of AstraZeneca, it's 12 weeks. You should go for second dose also?
Okay, so it depends when they got the first dose and when we're talking about the second dose. Are we talking about the second dose within this cycle? Or are we talking about the second dose in the next season cycle? Right? So this is the question, because right now we're at the end of this first cycle of the vaccine. I believe that the vaccines that will become available in the fall are going to be modified and they're going to be different. So when you have a modified vaccine in the fall, then of course everybody should get the booster dose. Yep.
Thank you. Now, thank you very much, everyone. If we have no more questions, I'd like to move on to just a quick update from everyone on what's happening in their home countries. Can we start with Dr. Pillai? Are you around, Dr. Pillai? Maybe you can.
Yeah, thank you. So in India, we are more or less settling down. The second wave is receding. At the peak of the second wave, we had almost 4 lakhs of people getting infected per day. Now it has come down to 1.2 and even less. So that is a great relief. Immunization, definitely vaccine administration is going on a large scale. And by now we have vaccinated 17 crores of people, more than the number who has been vaccinated in America. Regarding the infection profile, the Delta variant, that is B16172 variant, even in spite of taking 2 doses of vaccine, there is chances of reinfection by Delta variant in India. But then the infectivity definitely is higher, but the duration of infection has come down, maybe 1 week or even less. By 1 week, antibody becomes negative. A trend that we see in India is that the more younger people are getting infected, and even children are getting infected. One interpretation of this is probably that the above 45, when many are getting vaccinated, the infection is spreading on to the younger age group. Even pregnant women, in the beginning, were not giving vaccine, but then the fatality in the pregnant women seems to be higher, and the Gynecological Society has recommended vaccination even for pregnant women, because it doesn't break the blood placenta barrier. So that again we have started giving. And children 10 years and above, vaccination has been recommended. And although it's not the priority group, it is being done. The mortality definitely has not increased, although the number of infected patients number are higher. The mortality has not increased. The duration of infection has come down. And but then we have seen that suddenly the patient crash, because happy hypoxia does not produce much of distress in these patients, and they go on with the infection, but then suddenly they are collapsing. So that phenomenon again we are noting. So this is in short the picture in India. Thank you.
Thank you, Dr. Pillai. Dr. Chaudhary, anything update us from Bangladesh?
Thank you so much. Actually, in Bangladesh, actually we are in trouble in the border areas mostly, and border with the India. And actually, the variants, this Delta variant is predominating with 80% mostly, 80% of its share. And actually, this is the number of deaths is around 30 to 40 per day, and the number of infections hovering around 1,800 to 2,000, like that. It's going on. So it's not much, but it's worrying. Situation is worrying actually here, because just
Sorry, Dr. Chaudhary, can't hear you. Hello. Oh. Perhaps we'll, Sarab, shall we move on to somebody else?
Yes, we can.
Yeah.
We have.
This is Dr. Chan, Alvin from Hong
Yeah,
Kong.
we have Alvin from Hong Kong.
Alvin, yes, please tell us what's happening in Hong Kong.
Your attendance
Yeah.
is half, Alvin, today.
Yeah, I'm sorry that I'm late today because of the clinical duties. Yes, in Hong Kong, well, we were so saddened to have broken the line of for since yesterday. All right, we had more than a month of zero confirmation of any COVID-19 cases in Hong Kong. So, but then yesterday there was a confirmed case of a 17 years old girl, a student, who had not traveled anywhere and did not have any history of contact, close contact with any confirmed cases. So this is a case of unknown origin, and it's also a case of it should be an UK variant. So this is another case of local community case of mutant variant, and that alarmed us with unknown origin. So while we had been happy for a week that we had finally got a zero case for a continuous month, but then now it's broken again. All right, so we were worried. Another worrying news is that we had a medical student who had intracerebral hemorrhage, intracranial hemorrhage, who had developed after the vaccination. All right, and that was also alarming and caused anxiety in not only the medical profession, but also, of course, in the whole society. So that's the update of the situation in Hong Kong. We are, of course, now given the carrots from the government. Finally, the government will provide 1 day off after vaccination for the civil servants. 4 months after the vaccination campaign is so late, you know, for them to be awakened. And so some people had thought of some punitive penalties for those who did not get vaccinations in certain professions or careers or vocations. And of course, that was strongly objected in the society because people still think there should be a voluntary exercise. Okay, that's all the update from Hong Kong. Thank you very much.
Thank you, Alvin, and you look well. Thanks.
Alvin, how to help?
I'm going to have my second dose of BioNTech this afternoon. So I'm afraid.
Dr. Alvin, you can see this year Bhutan. Bhutan is having only 1 death so far, and they have all vaccinated actually.
Excellent.
Awesome. Yeah, that is a good thing actually. You can take the example from Bhutan, so that the more people will be getting the result. And more also you can see the US. I have seen yesterday that they are giving the incentives to the people for vaccination.
Did they get the vaccine through the COVAX program, or they are donated?
I don't know Bhutan
anywhere.
But there is interest. They have found the interest in the people, so that they have vaccinated their people. Even though there's casualties only 1. So
all right,
excellent. Prof. Ashraf, do you have anything to update us from Pakistan?
Yeah, Chairman. Luckily, Pakistan is a country which touched the peak, and we were having some problem. Not to be say that having the problem, but it was about the occupancy on the ventilator and the beds. It was 90-95%, which were allocated to the COVID-19 patients. But luckily now in Pakistan, particularly where I'm living in Lahore, Punjab, it was 18%. We touched about 24% of the positivity, but now it is going down and it is now about 2%, 1.5%. So Pakistan is safe in that. Just it is now worried about if we call as the variants over here in Pakistan, it was the British variant, which was more the cases. But now we have only 3 cases, not to say only 3 cases of the Indian variant, which we are concerned and worried about. And hopefully Pakistan is in a good shape, at least today. Thank you.
Thanks, Prof. Dr. Ravi from Malaysia, how are you? Anything to update us from Malaysia?
Yeah, thank you, Dr. Chong. Well, Malaysia, we are not in a very good shape. We are now in our fourth phase, and the cases are rising. It's at between 7,000 to 8,000 a day. But the worry is the number of mortality cases. We reached a maximum of 123 per day, and now we are around 90 to 100. We are in a total lockdown currently. Of course, when we say total lockdown, they still allow you to take away those working. The government has instructed that only 20% of the workforce be allowed to work. Certain sectors like the plantation sector and all are allowed to work in full force, whereby the management, of course, they do take the precautions necessary. Vaccination, well, the government is now trying to rope in the private sector to help them with the vaccination process, which means they provide the vaccines and the government does the private sector helps with the vaccination. But you know, as always, the government has got a lot of red tape, so this is being prolonged. But we are, because there's a lot of pressure from the public now that the vaccination process is very slow. We have had many of our doctors who are dying because of this COVID. We had a couple of people who have had the first dose of Pfizer, and before, just a day or two before the second dose, they landed up with COVID-19, admitted in ICU, and finally they have passed away. Now, this is quite frightening here. We have had medical frontliners who have taken the first dose of vaccine. There was no effect, nothing, no problem. But after the second dose of the Pfizer vaccine, she developed a severe reaction, swelling of the whole body and all these kind of things. So there is a big group here who are not interested in taking the vaccines. But as usual, I think in any part of the world that is the same. The government is still encouraging that everybody should be vaccinated, at least to attain the herd immunity. And so we are actually relatively concerned in this country here. Thank you.
Sorry to hear about that. You just across the border from us. So sorry to hear about all these things going on. Dr. Angelique and Dr. Hussein, anything from South Africa for us?
No, except again that we are moving nicely into our third wave. We seem unable to curb the numbers. And I think officially, maybe by the end of this coming week, we will be officially in the third wave. Unofficially, we're already in the third wave. Again, difficult to distinguish between mild COVID and mild colds and flu. This is our flu season. Difficult, very, very, very difficult. We're trying with the antigen tests at point of, at primary care level when patients come in. We know that the antigen test is also not 100%, and you need to follow it up 3 or 4 days later if the symptoms increase with a PCR. But it is what it is. It's difficult, and we have a very, very a spell of very cold weather this last 4 or 5 days, and I predict that next week we, as I said, we will definitely get over 6,000 cases in the country. But for now, we are just trying to get through the winter. Thanks.
Thank you, Angelique. Dr. Shastra from Nepal, do you have anything to tell us?
Thank you. Very good morning, all of you. Nepal, the second wave is very dangerous and very rising up tremendously. Since last 1.5 months, there are 8 to 10,000 per day infected cases are reported, and death rate are 150 to 200 per day, but since last week, it's slightly decreasing, 100, near about 100 per day. The death rate is reported. And regarding the vaccination, all the health worker are vaccine, all the health worker are taking the vaccine, but other people are not taking. The COVAX vaccine was given 65 plus first doses, only first dose was given. There is no available second dose. But nowadays, it's a very serious problem in our country. There is no oxygen supply, very scarcity in oxygen supply, and bed also very scarcity. ICU also same, and ventilate. The rate of the death rate is very high when the patient is in ventilate or ventilation. It's exhibited, it's very less number, less than 1% is recovery rate.
Wow.
Other things are is normal, but now 1.5 month the government has lockdown. It's a very hard lockdown. I mean, strictly to not to go outside. Only morning 1 hour is open for normal activities. There is so travel status in Nepal. Other are nothing more than this. Thank you.
Sorry to hear this, Dr. Shastra. Our thoughts are with Nepal. And Dr. D'Souza, anything to update us from Melbourne?
Well, we are in Australia. We are having a bit of a worry. As you know, Chong, you got investment in Melbourne. Yesterday, the whole country has gone into a state of shock because they've got 5 or 4 Delta from India, and they don't know how it came. This is a family that returned from New South Wales on holiday have come up with this Delta, and they cannot find how this person got it. They are still trying to do this. So that has caused a bit of a worry. The day before, they continued for another week of lockdown, but opened up for regional. So Victoria, Melbourne is having it, but not the country. You can't go to the country, only 10 kilometers. So the big worry is now the Delta come in. And they've never had this before. And so there's, and they cannot find the trace, they can't find this. So this has caused a big problem. So all are in a anxious state at the moment because of this. And I suspect that this will, our lockdown, which is supposed to be finishing on Thursday, will probably go get till they find what's, get a control or to get an understanding of what's happening. Other than that, of course, we've had 4 cases. The total number of active cases may be 120 in the whole country. And I think there's only 3 people in hospital. No one in the country is in intensive care. But a lot of, and I think again, the vaccine, that is an issue with some hesitancy. But ever since we had this in Victoria, there's a rush. Now there's a big rush of people coming, and they are struggling. The GPs, and they've opened up centers, so they're struggling to, and they've opened for below. Before it was only above 50, now 40 to 50, and I think anyone. I mean, there's some issue. They're going to. They're on the verge of bringing mandatory vaccine for those who are working in the aged care. At the moment, we've had some problems because the staff there haven't been fully immunized or they didn't take it. So yesterday's meeting was on the verge. They're waiting for the states and so forth to bring in. But the Prime Minister has announced they're on the verge of mandatory vaccine for those who are going to be working for the workforce in the aged care. Right, so that's the story of the Delta. How it came here, no one knows, and that's the TV, and that's what is the current worry. Although the total number of cases, we had, I think, in the last 24 hours, I think 2 cases or something like that. In Victoria, in all of Australia, 4. Compared to the rest of the world, it is relative. But remember, till last week, we had 83 days without a single case, and it's happened now.
Yes.
Anyhow, that's all I could add there. So we are all in that state of, everyone's worried about this. Because another thing is that we haven't done too well in the vaccine. This is a population that isn't very well immunized. Immunization has been rather slow. They took it easy because we had virtually no virus. They were almost in the elimination, so no one was worried till this happened. And now there's a rush. Now there's a sudden, all these things have happened, but they were lethargic or complacent, put it like that, till now. And so that's the problem. We still have a group, as Ravi said, who are anti-vaccine, anti-lockdown. They are protesting and they're being arrested, and this is going on one side. So that's where we are.
Thank you, D'Souza, Dr. D'Souza. Thank you. And in Singapore, just to update everyone, yes, we had the Delta here, and the serial interval is very short. From our efficient contact tracing, we can tell you the serial interval is about half now, about 2 to 3 days. So it's highly transmissible. The other thing is that our vaccine program is quite decent. 5.5 million population, we've already hit 4 million vaccinated. About 2.2 have received first dose. The other 1.7 received both doses. So now we're vaccinating children as well. So we started with school kids, sent out an SMS to parents of 50,000 kids, 25,000 responded with a yes. And I think the last few days we've vaccinated about 8,000-9,000 a day, but we're on the watch out for that myocarditis thing that Monica was telling us about. And also planning to roll out to breastfeeding and pregnant women shortly. Authorization has been given, or anyway, the blessings have been given. So that will be another thing. And we are also, otherwise just 7 cases as of yesterday and 1 unlinked. We are watching the unlinked cases because our contact tracing is quite efficient. So our ring fencing is pretty good. 6 cases were all developed in quarantine already, but we have 1 unlinked case. So that's the one we're watching, as what Alvin has said in Hong Kong. We're watching all these unlinked cases because we don't know where they come from, like in Australia. I suppose in Australia, it is a problem of success that you've controlled it so well that nobody feels the need to get vaccinated so soon and so urgently. Okay, without much further ado, thank you very much. Yes, Dr. Chaudhary, yes.
Dr. Chong, I couldn't finish my talk actually.
Yes, please. Yes.
Because of the interruption of the internet actually. So
Yes,
actually,
please.
I just have a query to the Indian Medical Association whether Dr. Pillai can help us. That actually, we started vaccination here with the Serum Institute's vaccine, that is the Oxford AstraZeneca, and we have paid actually for 30 million doses. But thinking that it will be continuous supply, but all on a sudden India got this year problem with the COVID, so they stopped this year export. So can the Indian Medical Association can help us, because the government started vaccinating and not keeping the second doses intact in reserve, but they continued it. All on a sudden it stopped, and so 1.5 million people actually they are not getting the second dose. We are not getting any from anywhere in the world. So can Indian Medical Association can have if we send a just plea to the association? So can Indian Medical Association can influence the government?
We can
donate. Sorry.
We can definitely take it up with the government.
Yeah, thank you, sir.
Supplying vaccine to Bangladesh, definitely.
Thank you, sir. Thank you, sir.
Thank you, Dr. Pillai. Dr. Chaudhary.
I think we have also Dr. Marie, which
Marie,
was left
yes,
out,
yes, I know.
from Japan, and also
uh,
Mr. Yeah, so
and
Miss
who else?
Marie.
Marie?
Oh, yes. Thank you very much. Can you hear me? Yes.
Yes.
And fortunately,
you.
we experienced the peak out of the fourth wave, but the government would decide to mild lockdown 3 weeks more. And 5% of the people, population, have received the vaccination right now. And also, we decided to export the AstraZeneca vaccination to Taiwan and Vietnam. So I will report to the chair of the president of JMA about the condition of Bangladesh, and I hope we can export the vaccination to Bangladesh too. Thank you very much. And we are reporting the new variant of English variant. So that is very transmittable to the younger generation. So we are very worried about what will happen to the next. And unfortunately, the government still not postpone or cancel the Olympics yet. Thank you.
So
Thank you very much.
Is that Marie? Marie,
yes.
This is Alvin.
Yes.
So JMA
yes.
also would advise the Japan government to hold off the Olympics, not to hold the Olympics this year. Is that right?
They are not announcing officially because the political condition is very tough in Japan. So it's not allow them to speak about the Olympics if they are from the JMA.
So no
It's
official staff. Thank you.
No official. Thank you.
Can I also
May
invite?
I say a single word, Mr. Chong?
Yes, Sarah.
Dr. Chong?
Yes.
One
Yes.
thing I think what Mr. Chaudhary has talked about, the issue of the Bangladesh about the vaccine, I think this is one of the major responsibilities or the actions by the CIMAO. Why not to request the Secretary General of the CIMAO to write a letter to Indian authorities? And certainly I appreciate the efforts and the statement by my colleague on behalf of Indian Medical Association. But I think as a CIMAO member and being the first vice president of the CIMAO, I think it is our responsibility too to act in and request the Indian government through the CIMAO channels to help our friends in Bangladesh. Thank you.
Thank you so much.
Can I also invite Dr. Salma? Can I also invite Dr. Salma, President for Pakistan Medical Association? I think she's just joined.
Oh, okay. Yes, please. Dr. Salma, please.
You have to unmute yourself, Dr. Salma. Yeah.
I was saying hello and good morning to all. It's a pleasure listening to you all. I'm sorry I joined late because I was in a meeting. So the situation in our country is, alhamdulillah, improving in the sense that people are becoming receptive to vaccination. I am principal of a medical college and I can see all my staff, the drivers and even the grade 4 people, the PNs and the janitors, they're all going and they're getting vaccinated. And they're also vaccinating their families. So this is a little change which I've noticed in 6 months' time. And now our NIH has also started producing the vaccine, though the batch is less, it is 170,000, but at least it's a way forward. And Mr. Nizami will bear me out, Mr. Nizami. We better write letters to our government to do something about the oxygen supply, which they were saying. They'll do something with the Karachi steel mills and give us more oxygen. So they should have proper vaccination now in very high quantities. And I'm very happy with all the good things that your countries are doing. Stay blessed and stay protected. Thank you.
Thank you very much, Dr. Salma. Thank you. Anyone else I've missed out or would like to say something?
I don't know. Is Dr. Brahm Vasudev there? Would you like to have a word? Would you like to speak over here? I'm not sure he's available or not right now. Anyways, I think he's in US. It's pretty late. If he's available, please unmute yourself. Otherwise, Dr. Alvin. Yeah.
Yes.
Yeah. Thank you. Thank you. Yeah. Thank you, Mr. Chair. I have a point to make because I was late today. I just wonder if the presentation today could be sent to the WhatsApp group so that we could learn from today's lecture. Secondly, I had some queries on the alphabets representing different variants in a way that, in fact, I think the WHO worried there's an effect of stigmatization. But then I think all along in scientific world, in the virology world, people have been using this nomenclature. Say, for example, in our influenza vaccine, we always have annual strains listed on the vaccine. So this has been a practice for a long time. So I don't think if we could use this alpha to delta, that could really exhaust the so many variants that have occurred already. So now the variants in Vietnam have been more dangerous in a way, but then we still have to say that the variant from Vietnam, and in fact in Chinese, we don't have, I mean the media, the newspapers, they don't have the alpha, beta, or delta, or these Greek alphabets to print on. So I don't think it's practicable in Hong Kong to fully use this nomenclature. So I don't know how it's like in Singapore, because all you have English as a media. But in China and in Hong Kong, I don't know how the people could really get used to this nomenclature, new labeling system. Thank you very much.
Yeah, they might run out of alphabets because there are only 26.
We have to get used to it.
Okay.
Yeah.
Thank you all very much for today's session. Because it's running late, the last time we overran and wasn't very nice because the next group started coming into the Zoom. So thank you very much, and especially Dr. Rohit Agarwal for the presentation, and for Monica for telling us a lot of other information from all the queries that everybody had. So as usual, always a great session on Saturday, and we always look forward to these sessions and learning a lot from each other, and being updated on all the various situations in all the various jurisdictions throughout the world. So thank you all very much, and much appreciated. I look forward to seeing you all, everyone again next Saturday, and for more discussions and more information and more exchange. Thank you so much.
Thank you very much.
Thank you.
I also wanted to
Thank you. Bye.
Thank you.
I also wanted to
Yes,
announce that for the next week we will have a session on mental health, a speaker again from US. I will also put the questions, and if anybody has a pre-question, they can send it to me. I will send the topic today or tomorrow. I also want everyone to, if you can save my number so that I can create a broadcast list, because a lot of people do not check the group message, I realized. So I sent individual messages today, but because it takes a lot of time, so if you can make a broadcast list, I can do the broadcast list. So if you can save my number, you already have my number, so I can do that. And we were live on various platforms on YouTube, Facebook, Twitter, or almost like 9-10 platforms there. And the news is getting spread, the messages are getting spread. So I want all the people to get associated on this International Speaker Forum platform. And we are blessed. The session which was started by Dr. K.K. Agarwal, the legacy is continued by his family and friends. And I'm sure he would be very happy, because this is one session which was very close to him. And I always, when he started the session, I remember there were only 2 people who joined in the first few meetings. And I was saying that, why do we need to do this session? There are only 2 people joining in. So he says that unless you make something creative, people will not join in. Unless you make something very useful, people will not join in. And you will see what will happen after a year. And he was correct. More and more people were joining every day. He was getting a lot of attraction. Obviously, with his skills and knowledge, what he had, it was unmatchable. But again, with the help of you guys, with the help of Simao family, without help of extended family, the story is on, the show is on. And with this, I would like to conclude this meeting. See you next week again. Thank you, Dr. Chong, for being with us. Thank you, Dr. Rohit, for being as a speaker. Dr. Monica, again, for helping us out for this, and my entire team and Simao team, which is there. Thank you so much, everyone, for this session.
Thank you for